part of the liquid biopsy paradigm that we have now, and it includes not only circulating free DNA but also circulating tumor cells. Okay. As an introduction, the clinical decisions, of course, are based on tumor genotype, and the genotypes only represent a snapshot of the tumor at the time that it's taken. And it requires tissues that are difficult to obtain, especially in the metastatic setting. Targeted therapies have changed, and cancer treatment have provided a lot more opportunities for our patients. But with that, also, we are seeing much more resistance in these patients. And there's a need for us to develop tests that will be able to identify the heterogeneity of the tumors, as well as the clonal evolution and selection of these tumors that contribute to the resistance and recurrence of disease. So there's a need for many tests, for biomarker tests, that will be able to measure temporal changes in a specific biomarker that's associated with the tumor over time and during treatment to detect evidence of recurrence and to provide an insight into the underlying mechanisms of resistance. The liquid biopsy, of course, is intended to do this, and it has to have certain characteristics. It has to be non- or minimally invasive procedure. It has to be relatively easy to operate, to acquire these tests, to be able to perform them. And they need to have a direct effect on being able to identify temporal changes in the biomarkers that are disease-specific. It needs to be rapid and cost-effective, and that's one of the limitations that we have so far in many of the tests that are being used. They're not very cost-effective, but in time I suspect they will be. And they have to be useful in that they provide a surrogate assay that will eliminate the need for tissue biopsies, especially in the metastatic setting. The biomarkers identified using these tests have to be associated with evidence of recurrence and provide us a better understanding of the mechanisms of resistance. There's already one of the tests that's been used for the last 15 years as a liquid biopsy, and that's circulating tumor cells. And I've discussed this with you on many other occasions in previous years that I've been here. Now there's another test, the circulating free tumor DNA, that's being utilized, but it's not very well used in many of the clinical trials as yet, and we are just getting organized to do that. So circulating tumor cells, of course, are intact, viable tumor cells that are of epithelial origin, circulating in the peripheral blood of patients. They are more prevalent in patients with advanced stage diseases, and we and others have showed that these tests can be predictive as well as prognostic, especially in the metastatic setting, but there have been more recent papers now coming out showing that even this test might be even much more useful in early breast cancer patients. The assays used to identify circulating tumor cells are fairly simple and very well accepted. They're using cytochemical staining, RT-PCR, and the FACS analysis also is used on some occasions. And there's even one test that actually looks at the function of CTCs. But with all of these developments, though, there's only one test that has been approved by the FDA, and that is the cell search system, which captures epithelial cells from peripheral blood using antibodies to EpCAM, and then performing a cytochemical staining of these cells for the presence of cytokeratin. They have been established, we have established cutoffs now for what's relevant using this test, and in metastatic breast cancer, it is a minimum of having 5 CTCs, whereas in early breast cancer, it's having any CTCs as low as 1. But this test suffers from some of the drawbacks, and that's its sensitivity is only about 65% in metastatic breast cancer patients. So you can see that about 1/3 of the patients, we cannot detect CTCs, and that's the limitation of the test. And there are other tests, such as the ADNA test listed here, that utilizes an RT-PCR-based mechanism to be able to identify these patients. This slide is dated, and you can see that many of the cancers, in many of the patients in metastatic disease, you can identify CTCs. But one interesting thing here is that most of the patients that you see would have between 20 to 30 CTCs. So the dynamic range of the test is very limited, except in very few cases where they have more than 50 to 100 CTCs. This slide shows that the CTC test has been very well accepted as a prognostic tool in breast cancer, colorectal, and in prostate cancer. And on this slide, we show that in breast cancer, if you have more than 5 CTCs at the beginning of starting with new therapy, then your prognosis is for a shorter progression-free survival as well as overall survival than patients who have less than 5 CTCs. Similarly, this has been described in colorectal cancer with a cutoff at 3, and in prostate cancer with a cutoff of 5 CTCs. Later on, it's also shown that this test can be used as a predictive value, also, because if you, at any time point in a treatment cycle, if there's a reduction in CTCs below 5 in patients, then they seem to have a better overall survival. So not only is it prognostic, but it's also very predictive. It can be used as a predictive assay. Now to get to circulating free tumor DNA, the purpose here, of course, is to identify tumor-associated mutations that are found in the tumor in peripheral blood. Can we detect them in peripheral blood? So we are looking for DNA fragments that are mutated, that are in peripheral blood, typically in plasma, and the distinguishing factors between normal fragments of DNA fragments from normal cells undergoing apoptosis versus those of the tumors, that the fragments of the tumor are much larger than what you see with normal cells. This DNA is not associated with cells or cell fragments, hence the label free, and it's secreted from the primary and metastatic sites as well as by circulating tumor cells. And the tumor cells are undergoing either apoptosis, necrosis, or lysis. It's detectable in advanced stage disease patients, and the sensitivity is purported to be around 80%. However, that has been challenged in some of the more recent papers that have been published. There are many methodologies that are used to describe, to detect mutated fragments in peripheral blood. And as shown on this slide, the majority of them are, as you can see, the top ones where they're very sensitive are the ones that are used for tumor tissue, and also it's very laborious as well as very expensive to do these tests. Most of the peripheral blood assays that have been done are restricted to beaming or digital PCR, and those are readily, the prices are coming down, so they will be more adopted into clinical trials. The typical strategy for identifying cell-free DNA is shown on the slide. Typically, one gets a tissue biopsy from either primary and or metastatic site. DNA is extracted. It's undergo direct sequencing to look for mutations. Contemporaneously, a plasma sample is acquired from these patients. DNA is extracted, and there are 2 assays that are done. One is a real-time PCR to detect total fragmented DNA, total DNA in the sample. That includes both normal as well as fragmented DNA from the tumor. And to distinguish these two, then a beaming assay is performed where you can distinguish normal circulating DNA from that of tumor. Here's a representative slide now that shows that if you look at it, the best scenario here is looking at a patient pre-surgery, post-surgery, the initiation of recurrence, and then the total development of progressive disease. And on the x-axis here, you're looking for mutated fragments of DNA from the tumor versus the total or the wild-type DNA and on the y-axis as you look. And if you look at the first panel where it's pre-surgery, you see that the green cells, as shown on this slide here, are related to the normal fragments or the wild-type, and the red dots are representative of the mutant fragments of the tumor. The blue intermediate cells that you're looking at are stained by both the normal as well as the wild type. And in the pre-surgery stage, you're looking at patients who would have around 13% of the mutated fragments. And as 3 days after surgery, there's a total disappearance of this, and there's negligible amounts that can be detected. However, when patients are beginning to develop recurrence, there's a slight increase to 0.11%, and with full-blown progression, you see the presence of the mutated fragments much more prevalent. The frequency of detection of cell-free DNA in metastatic patients is quite good. In about 50% of most cancers listed on the x-axis of the slide show that about more than 50% of these patients will have the presence of cell-free DNA. One limitation is that at the right corner end, you can see that in patients like glioma, where there's a blood-brain barrier that restricts the secretion of these fragments into peripheral blood, it's very difficult to detect cell-free DNA. However, not all fragments or not all DNA in the peripheral blood is of tumor origin. And there's a need there is a requirement that you distinguish between normal and tumor-related fragments. And here you can see that in those patients that had detectable DNA, there's a wide range of percentage of that is related to tumor fragments. And by the distribution here, you can see that there are patients who have very low levels, and there are patients who have very high levels in any particular disease that you're looking at. So it's imperative that you develop an assay that's going to be very, very sensitive with a high enough dynamic range to capture the low end as well as the higher end of these patients. The ability to detect cell-free DNA also is high in patients with metastatic disease. Here are 4 representative cancers: colorectal, esophageal, pancreatic, and breast cancer. And the dark blocks or the histograms are patients with a localized disease versus the cleared bars which show patients with metastatic disease. And in each case, you can see that the metastatic patients are more likely to have circulating DNA that's tumor-associated. The frequency also increases with stage of disease. So patients with the highest stage of disease or metastatic disease, stage 4, would have a better chance of detecting cell-free DNA in their plasma. And also the ability to detect the concentration or to measure concentration in these patients, where you see that patients with high-grade disease will have a higher level of cell-free DNA that's mutated. But also, another reason to point out here is that the distribution is quite variable, and there are patients at low stage that have very high levels, which actually parallel the median level of patients with very high stage, with higher stage disease. So again, this brings out the point that the test has to be sensitive enough and also have a dynamic range that's large enough to be able to detect both ends of the spectrum. A few examples now of metastatic disease. There's a study by Dawson et al. In New England Journal that came out last year, where they took 52 breast cancer patients and they looked at two different mutations, P53 and PIK3CA. And of the 52 patients, they had 30 patients that also had serial blood samples that were drawn at the time throughout the treatment. Of the blood samples that were drawn, there were 141 that were available for ctDNA, 114 were available for CA15.3, and 26 were available for CTCs. Here are some of the representative patients that they saw. In patient number 1 and patient number 6 in plot A, this patient had a structural variance that was very close to the amplified locus of the mutant DNA. So when they amplified it, there was co-amplification. In B, C, and D, these are patients that were treated, and you can see that by the shaded bars, those are the areas that were treated with either hormonal or chemotherapy, and where the arrows at the top when patients had CT scans for staging of the disease. In panel B, you can see that there was a patient that had 6 mutations in the tumor, and all of them were able to be followed in plasma, and they all dropped when the patient achieved stable disease. There was a reduction in levels of these mutations, and when the patient progressed, these mutations also increased in concentration. In panel C now, there's a patient here who had very non-detectable PIK3CA and had P53 levels that were high in the peripheral blood. And you can see here that even though treatment, when the patient may have achieved some kind of a stable disease, there was no change in P53, and the PIK3CA was not very informative. And finally, in D, panel D, this patient had only P53 in the plasma but not in the tumor. And as the patient got treated, even though he achieved or she achieved a stable disease, the plasma level of PIK3CA dropped, but the P53 mutation did not drop. So again, there's quite a heterogeneous profile that you see in these patients. It's important that you design your trials so that you'll be able to evaluate individual patients with these results that you have. Now there's a comparison that was done in the same study where they looked at 3 different biomarkers, ctDNA, CA15.3, and CTCs. And here in the top panel, they're comparing CA15.3 to ctDNA. On the right-hand side in the graph, on the x-axis the ctDNA, the y-axis the CA15.3. The dashed line across there is the cutoff. Is a cutoff value of 32 units per milliliter of CA53, which is the threshold. And you can see in this graph that there are many patients who have high levels of ctDNA but that don't make the threshold of C53, 15.3. There's a very low correlation of 0.36, but it is highly significant. Of interest also here is that the ctDNA had a very high sensitivity, around 80-90%, whereas the CA53 is around 70%. In the lower panel, there's a comparison between CTCs and ctDNA. And here you see again, on the graph on the right-hand side bottom, there are 2 dashed lines. The lower line represents CTC levels at 1, and the higher dashed line represents CTC levels at 5. And here you can see again that there are many patients who had high levels of ctDNA, but were negligible. The CTCs could not be detected in these patients. There's a correlation between the 2 assays around 0.6, which is better than what was previously shown for CA15.3, and was highly significant also. Hence, because of this, of course, you see that ctDNA had a higher sensitivity than CTCs. However, one of the major criticisms of this paper has been that they only use cell search, which has limited utility in detecting all the heterogeneous subpopulations of CTCs. Had they used additional tests to identify other CTCs that were undergoing EMT mesenchymal transition, then they may have had a better correlation, and they may have had a better sensitivity also for the CTCs. Here you're looking at 4 patients now, where you're following all 3 tests longitudinally. And in panel A, you see that, again, they are along the x-axis, we're looking at days post-treatment, and y-axis is looking at the level of the marker. The 2 lines that are dashed, as you see, the lower line represents the cutoff for 5 CTCs, whereas the upper dashed line represents the threshold for CA15.3. And you can see that in panel A that the CTC levels are not very high. Also, you don't see any much fluctuation in the CA15.3 with treatment, even when the patient was in progressive disease or unstable disease. However, the ctDNA levels fluctuate quite a bit because of the dynamic range, the high dynamic range that it has, and it reflected the stage of the disease of the patient. In panel B now, CTCs were below 5, so they're not very informative and they didn't contribute anything to the study. Whereas looking at CA15.3 and ctDNA, you can see that they pretty much track each other and are very related to the patient's disease status. And you actually see there's a slight increase in the levels as the patient goes into progression. In panel C, you have now CTCs that were not detected. So it's completely out of the equation here. Also, CA53 was below the detection threshold of 32 units per mil. So again, that did not contribute to anything to following this patient. However, the ctDNA did show some changes, and as the patient went into stable disease, there was a drop in. Okay. Next slide. Can I go to the next slide? Maybe with another 5 minutes. Yeah. I just want to show you at the bottom, at the bottom here, where CTCs and ctDNA were shown. They show that around 2,000 copies, ctDNA was significant in that it shows the patients who had a very high risk for hazard ratio was increased, and that corresponded around 5 CTCs. And finally, in this slide, you can see that ctDNA was able to detect all the mutants that were both in the primary as well as in the metastatic tumor, which were individually quite different. You can see here that the patients with the primary tumor had fewer mutations than in the metastatic tumor. However, after when this patient was being treated with an AKT inhibitor, you can see that all of the mutations were present, and with treatment, the mutation levels dropped. However, as the patient was continually treatment and was having recurrence of disease, all of these mutations appeared again. So finally, this ctDNA can be used to detect not only early detection, but also to follow patients throughout therapy. It's much more prevalent in metastatic patients than in early breast cancer patients, but it can be useful in looking at following specific clones in mutations as well as that might contribute to the resistance of disease. Thank you very much for your attention.
Thank you very much, Professor James. And now we move to the next speaker, Professor Benu Aaron. Professor Benu is a professor of breast medical oncology from University of Texas, US.